which is important as WHO identified, the disease of poverty, economic, distress, vulnerabilities, marginalization, etc. I think it's very clear that there is a deprivation in terms of whether it is a physical, psychological, social nourishment. Okay, so that's the reason why it is the disease of the poverty, along with the physical symptoms of pulmonary tuberculosis and extrapulmonary tuberculosis. There have been emotional, psychological, economic issues that are involved in this disease. Okay, and a higher quantum of all above issues seen in drug-resistant tuberculosis. So there are issues for such a disease, and they can, increase if it is drug-resistant tuberculosis. Secondary illnesses such as anxiety, depression can increase the comorbidities, occurring the comorbidities in TB patients, and may negatively influence the quality of life and therapeutic result. So this is a very important aspect to look at the mental health in children, psychiatric disorders, in particular in tuberculosis patients. Due to its long treatment, remember, when the absence of health is for a longer time, or repairing of that healthy problem is for a longer time in terms of the treatment or whatever. That chronicity of treatment probably contributes emotional negativity and even disorders in children. Okay, the natural history of tuberculosis is modified by all these emotional factors. Any disease, if it is on home or if it is hypertension, lifestyle, remember that positivity, probably would make every attempt to change the behavior towards positivity, which will improve upon the health aspect. And that is exactly applicable to tuberculosis also. The various states of mind and intake patients and indifference, depression, and anxiety all can lead to a problem or cheerfulness or positivity can lead to improvement. WHO, the United Nations Agency, now who are dealing with tuberculosis, make a point to develop a program where the tuberculosis and mental health come together. Okay, so now the program which comes on tuberculosis, whether it is eradication or whether it is treatment, management of resistance, mental health becomes an essential component that contributes in terms of the better prognosis. So having TB can lead to mental health challenges, decreased ability to work due to illness, and there is a lot of rejection from the society, leading to the stigma. And stigma is a challenge. In our society, like Asian society, or it is American society, or it is European society, stigma of particular behavior is always a challenge. Okay, and remember that the face of the stigma keeps changing, but it exists. Something which we as a behavior scientists find difficult to understand the whole dynamic of the stigma. If there are people who are wrong, for example, who believe in lying. Okay, I will give you the example. The people who believe in lying, and there is a person who talks the truth. Now there will be stigma on the person who talks the truth because he is different than the people who lie. So stigma dynamic is like that, and that's exactly what happens in the disease process. Mental illness is linked biologically to an increased incidences due to inflammatory or suppressive effects and decreased adherence to taking medication. Stigma is because people want to hide that there is no such illness. And best way of hiding is not to, expose to anything that is related to the illness. And what is related to the illness? Most obviously, most explicitly, that is the treatment. The minute you take the treatment changes the people's attitude towards not only towards the illness, mainly towards that focus in terms of the deprivation of a simple thing that is social integration. That person probably doesn't get opportunity to socially integrate and do the thing. Okay? Studies between 2000 to 2019, they have most of the studies have proven that depression, anxiety, alcohol use, and non-specific categories of general well-being. Okay, like to see that mental health is deteriorating doesn't mean having depression, doesn't mean having anxiety. For example, as a student, as a worker, or even as a teen, if I feel my productivity is gone down, it probably is an important factor for me to face my emotional or my mental health. What is it that reduces my productivity? So, mental health is a category that is closely linked to the life and living of the human. Okay, that's why it is so important in children and in particularly in the diseases like this. The relationship between TB and mental health, is very important. Mental health illnesses are up to 70% of the people. Maybe right from the adjustment disorder to the depression to many other things. Okay, and the high rate included two-way effects of anti-tuberculosis medication and those used to treat mental illness. Okay, so this is something which we need to understand. And anti-TB medications such as cyclosporine and rifampicin, which certainly have cognitive and even the mental health problems. Okay? Depression in persons with tuberculosis range from 11.3% to 80.2%. Okay, the prevalence of depression in individual studies in from India to Zambia, Zambia and that is 9, right? So I think the range is wide, and that's the reason why country like India, where vulnerability is low, okay, we have to really together mental health perspective. It is highly female, similar that neurologic illnesses like depression, anxiety, generally are more in women, and it's related to both her biology as well as her social status, which is more often deprived than individual. Okay, in this situation. So that is where we need to understand this particular index. Depression was significantly linked to non-adults. Why depression is important? Now, identifying depression is important even in lifestyle diseases. For example, somebody is having diabetes. Okay, like tuberculosis, the person will not be motivated to take. Okay, in fact, there are now studies. If you take depression properly, people become motivated to get involved in this. A depressed person probably having negative vibrations about them. So, क्या करेगा है जिसको हमारी that kind of negative cognition will lead to people not taking treatment, and that's the reason why looking at the mental health perspective and identifying illnesses like depression, etc., will lead to better improvement. Like I will talk about Shivhari hospital, which I keep talking. The cases of suicide with depressions were reported in a real time. 6-7 people, committing suicide in the hospital center. That was happening when I was being there in the Kenyan hospital. Now, after that, the change which has taken place, which is very important, is the psychiatrists were appointed in Shubhangi hospital for looking after this thing. And that's the reason why we have to look at the mental health. Then there is a lower success rate with the treatment, shorter survival time with the first 6 months of the follow-up, loss to follow-up which happens, and this. In a sense, this is very important. As a medical, we must know that how depression can cause death. One is suicide. The second important reason is neglecting self with that disease can, get into the brain of the person. This is a very important perspective. Why should we think about it? Okay, a patient with tuberculosis, maybe with lifestyle diseases like hypertension or diabetes, will do better and will have a little longer life or better life if we treat depression properly. And that's the reason why our GPs were doing well because they were not just talking about the disease, they were identifying the demoralization reactions today, even depression, and that needs to be treated if we want people to be involved in their well-being. Okay, so depression in persons with drug-resistant tuberculosis, it is much higher. Remember that it is much higher in drug-resistant because there is a negativity, there is a feeling of, there is a feeling of not Mumbai. So we have to understand the place like the audience as well. The people who don't knowledge to understand what is happening, they probably can be suffering with lot of rejection, which push these people not to get well lifestyle. So we have to understand that counseling is a skill which requires to be learned at some level and should be developed properly. Counseling is not just software. It has focus. What is that I am going to talk about? Okay, so that is something which is important. Counseling came in a very strongly public health platform during HIV. That time the counseling was something which was spoken about. But that's very important for each and every medical professional at some point of time they would require to do kind of counseling. And support system is very important. So all these things are clear. This is what I wanted to say about counseling. It is a strategic point to understand tuberculosis in terms of types of anatomy, through the symptoms and through the treatment. I think medical people require to be more human than any other profession. Okay, and that's what my talk is today. Thank you so much.
Thank you so much, ma'am. Your expertise adds great value to today's CME. I would like to call Dr. Shivhari Ghorpade sir to offer Dr. Shubhangi Parkar.
Yeah, but before that, I must thank Dr. Ghorpade, Dr. Gayatwar, Dr. Jadhav for being here with us, Dr. Surbi for being with us, Dr. Neelam for being with us. It's great feeling to have you all, and it's an important day for all of us. To remember that the good life never comes about the rest.
Now, I would like to call upon stage Dr. Shubhangi Parkar, ma'am, Assistant Professor of Obstetrics and Gynecology of Vedantaa Institute of Medical Sciences, to share your thoughts on endometrial tuberculosis.
Hello everyone. So since we had looked into multiple aspects of tuberculosis, psychiatric, microbiological, TB, meningitis, liver effusion. So further, we move forward to tuberculosis. So looking forward to the epidemiology, to us in our OPD, 1% of the patient might present to us with gynecological genital tuberculosis, and this patient might not be diagnosed as patients may not present themselves with the same symptoms of tuberculosis. Okay. So it's an important cause for the female morbidity, short and long-term sequelae, especially infertility in the affected women. So of all the 100 patients who are coming with the complaints of infertility, 15 to 20% cause it might be genital tuberculosis. And of all the 100 patients with genital TB, 70 patients might be the patients in relation to their infertility. So the patients who are coming to us with the complaint of infertility, it's very important to rule out genital tuberculosis in those patients. So high suspicion of TB has been made in the patients presenting with secondary amenorrhea and normal bleeding, infertility, and chronic fatigue. Looking forward towards the pathogenesis, genital tuberculosis as might be microbacteria. Primary site of infection either it can be pulmonary or it can be extrapulmonary. Pulmonary cause lymphatic spread is the most common. Also, lymphatic spread. Extrapulmonary lymph nodes, bones, joints, urinary and gastrointestinal. The sites that have been involved in pelvic region. Fallopian tubes are most commonly to be in 90 to 100% of the cases. So, in a patient whom we have to rule out genital tuberculosis, most likely that fallopian tube will be involved. Next comes endometrium, is 50 to 80% of involvement, and ovaries 20 to 30, cervix 5 to 50, and pelvic vulva as well as vagina might be involved. Fallopian tube in case of genital TB, either the infection it might present as exosalpingitis or salpingitis. In case of endosalpingitis, the infection it spreads from endosalpingitis, it spreads from the outside layer. The site that is involved in fallopian tube is ampulla because of the abundant blood supply. So in case of endosalpingitis, as the infection is spread from the endosalpinx, the severe movement of the fallopian tube is destroyed, and hence the possibility of infertility in this patient is increased. Also, the possibility of ectopic pregnancy in this patient is increased, and thus it might result into formation of endosalpinx, pyosalpinx, and trichovinate abscess and other sedation. In case of exosalpingitis, since the infection starts from the outer layer muscularis mucosa, it further advances and it might result in the formation of ovarian mass, hydrosalpinx, and pyosalpinx. And thus hydrosalpinx, the patient might not complete and present with infertility. Here we can see the miliary tubercles which are present over the fallopian tube over the uterine surface. In case of ovarian TB, most likely if ovarian mass is present, if we are suspecting ovarian TB, definitely we have to look for the fallopian tube because the infection most likely spreads from the fallopian tube to the ovarian and thus resulting in the formation of ovarian mass. Abscess. Okay. Next, coming towards endometrium. So here basal layer of endometrium gets affected, and hence since the basal layer it is the regenerative layer, the patient might present to us with abnormal uterine bleeding. Many times, if the entire basal layer of endometrium is being disrupted, then the patient also might present with oligomenorrhea or hypomenorrhea as well. Service involvement of cervix will be there, lower and involvement of fistula formations might be there, and it involves either the involvement of tubes and ovaries, vulvovaginal fistula, vagicovaginal fistula, rectovaginal, and involvement of abdominal wall, involvement of bladder and bowel. Involvement of peritoneum, which might be dry variety of exudate. And on histopathology, will include inflammatory cells with multi-nucleated giant cells, also referred as nine cells, which are without initiation. They cross. Here we can see the causative nodules that is being present over the tube, over the peritoneum, in the pouch of Douglas, and also over the fallopian tubes. So what would be the clinical features for the patient apart from the key symptoms of tuberculosis? As most of this patient present to us only with a complaint of infertility. This patient might not be having any symptoms related to the tuberculosis. Okay, so either patient might be infertility, or as we have said, if it involves the uterine part, then patient might present with menorrhagia, or it might be anemia if the behavior of endometrium is involved. The others might be polyphenolia, intermenstrual discharge, chronic pelvic pain. In patients who are postmenopausal, in postmenopausal patients, the cervical stenosis might be present. So the first collection which occurs in the endometrial cavity, it might result in the chronic cervical discharge, false landing, and it might also result into pyometra, and thus resulting in pelvic pain. Involvement of vulva and vagina. There might be ulcerations which are painful, and it might be bleeding. Involvement of suffix, there might be painless lesion with blood stain discharge, and sometimes patient might present to us with postcoital bleeding. Any patient presenting with a cauliflower mass over the cervix, it might go into the diagnosis because he is cervix, not ruling out genital tuberculosis. It is also important to look for the it might be ectopic pregnancy, endometriosis, PID, appendicitis, or the patient presenting with EUD, abnormal uterine bleeding. Either it might be because of endometrial hyperplasia, endometrial carcinoma, endometrial polyps. In patients who are presenting with features of cervical tuberculosis, patient might have CSFX or CA. The patients present to us with ovarian TB, either it might be ovarian cyst, ovarian necrotic, or ovarian cancer. So, whatever be the diagnosis, we have to keep genital tuberculosis as a part of it, and we have to rule out. What investigations history taking past history, family history, very much important. Patient exposed the patient having tuberculosis, family history, if there is a having tuberculosis, patient who previously received treatment for tuberculosis and the injury current is there. So past history, family history, any history of diseases like patient is HIV positive or HIV, because the no infection with HIV and tuberculosis is very high. So we have to go with the thorough history of this patient. Routine investigation has to be done, and all the patients presenting with symptoms of CME or secondary amenorrhea always we have to rule out pregnancy. So whatever be the condition of menstruating patient having any menstrual irregularities, it is always the thing that we have to rule out with. As microbiological aspects are already covered regarding the multiple tests which can be done with small substance. Specific tests that can be done for the genital tuberculosis with the endometrial biopsy. So, before getting out this endometrial biopsy, we have to make sure that we have started active management for tuberculosis. Initial phase is being started. Endometrial biopsy, endometrial excretion cytology can be done. When to do this procedure? So, this procedure have been done in the late menstrual phase, starting from day 21 to day 24, and before this procedure, patient has to be asked to give sexual intercourse and prior to it. So, two samples have been taken, one with the normal saline and one done microscopy, culture, and molecular testing. So, your molecular study which we are going through with NAT, and either PCR can be done or a CPN expert or gene expert can be done. So the result specificity is 100% and sensitivity is 33 to 50%. Also recombinant resistance. Further, the sample which is being collected with the 10% formalin, we go with the histological examination to look for if there is presence of Lantan cells, if there is presence of cateation, epithelial cells, and other lymphocytes. What imaging methods will go through? So we look for the ultrasound, we look for the CT, we look for the MRI, we look for the PET scan as it is required depending upon the signs and symptoms of the patient. And imaging methods first ultrasound is the basic line of investigation. Here we can see the solid and cystic areas that can be seen. Mostly we see bilateral, it can be unilateral also. CT, MRI, PET scan depending upon the condition of the patient, depending upon the site of involvement can be done. So with the help of the PET scan, it helps us to differentiate between the tumor as well as the malignant cancer. If we have to look for the lymphocytes, then the analysis is probably the best. Also, the PET scan which is being used, it is important for the patient who had already completed the EKG treatment, tuberculosis treatment, and we have to look for whether the lesions are still active, whether there is recurrence or it is just a fibrotic lesion. Here you can see or notice a hypertense area that is seen in tuberculosis in the patient whose MRI approach is being done, while the other side here says is the increased FTG uptake in PET CT scans in the patient with genital tuberculosis. So patient is with hysterosarcophagy. Definitely patient who will be presenting to us with infertility. We have to look for the endometrial cavity. We have to look for the pH of diet, whether the COVID is being pregnant or not. We have to look for the pouch of Douglas. We have to look for the condition of the ovary. So we know this is hysterosarcophagy are with infertility. So what will we see in such patients? So it has been contraindicated in the patients who are being presented to us with active disease. At least minimum 2 weeks of the treatment has to be done prior. And if it can be done, then 6 weeks is better. What's the hysterosarcophagy findings? So here you can see elephant syndrome. Okay? There are multiple defects can be seen within the endometrial cavity because of the adhesion which is being seen within the uterus. As the basal layer of the endometrium is involved. Here, the first feature is the vascular appearance, that is, there is the presence of the tumor, and thus giving the appearance of a vascular. Another feature is the tobacco box appearance in the patient presenting with hydrosalpine. Here, in the patient, the abnormal blocks is being seen because of the addition, involvement of the fallopian tube at the vascular region, and other is the vivid appearance in the patients presenting Psychiatric medical produce appearance will be. Next, if we go with the laparoscopy, so laparoscopy we can look for the surface of the uterus, the involvement of the POD, the involvement of the uterus in the seen, and tuberculosis. What features is the material tuberculosis. Here is being seen, STD nodules are being seen with the surface, multiple adhesions it will be seen, and between peritoneal layers, hydrosalpine adhesion, and chemopurgation when done to look for whether the fallopian tubes are being involved or not. So here, tubercle and adhesion which is being seen over the surface, and blue sign that is involvement of the fallopian tube. When we inject insulin to die, the external cause to look for the frequency of the fallopian tube. Because of the tubal blockage, the active hydrosalpine and the blue distended part, and it is called as Sharma's blue alpha sign. Here you can see hydrosalpines, multiple adhesions that is being seen over on the surface of the liver. It is referred to as Shubhangi syndrome, and thus we have to look for tuberculosis in such findings also. So the patient presenting to us, if we are having diagnosis of tuberculosis, definitely we have to go with an X-ray test to rule out HIV test has to be done as for infection of TB and HIV is very hard. And UPT, urine pregnancy test has to be done. The patient is in reproductive age group presenting with menstrual irregularities and ultrasound is to be done as a part of a final investigation. The biopsy, peritoneal biopsy, laparoscopy, and the lesions which have been done. Who is the microbiological investigations, microscopy, culture, PPNet, gene expert, and victims of TB positivity have to go with the tuberculosis treatment. What are the patients who present the symptoms? Genetic tuberculosis. So, a premenopausal patient, if it is infertility and menstrual problems, definitely it is a presumptive diagnosis. Okay, present the patient might be having symptoms of like fever, weight loss, and cough also. Patient presenting with ectopic pregnancy and a postmenopausal patient presenting with vaginal bleeding. So, in a postmenopausal patient, not only it is we have to rule out with CS cervix and CS endometrium, but also genital tuberculosis turns out to be an important cause which needs to be ruled out. Treatment is being carried out 6 months treatment, 2 months with HR benefits, and 4 months continuation with the drug of HIV is to be done. If the patient is multi-drug resistant, then accordingly the treatment is given 9 to 12 months of TB. The management of anxiety in patients of genital tuberculosis. The if patient presents with hydrocephalus. So if patient is with hydrocephalus and with infertility, hydrocephalus the fluid in characteristic, the patient might not conceive. The ciliary condition of the fallopian tube is already there. So whatever the treatment will be there, patient might not conceive with the natural process. So what we have to do is either we can go with clipping off the fallopian tube so that the toxic fluid that has come in contact with the endometrial cavity and those patients can further go with the in vitro fertilization treatment for the purpose of their infertility. Once since the damage to the ciliary is already done, there is no other option and this patient has to protect towards the IVF after going with the squeezing of fallopian tubes. This was regarding the endometrial tuberculosis. Moving forward about tuberculosis pregnancy. So pregnancy as such it does not increase the risk, but definitely tuberculosis if present in pregnancy, it might increase the certain morbidity associated with the mother as well as the baby. So TB has been found significantly increase for the maternal morbidity and neonatal admission. Also, there has been found increased association with placenta previa, with PPH, with anemia, with sepsis, and often in the babies there was the increased risk of preterm delivery, low birth weight, fetal distress, and birth spike. WHO has proposed a four-symptom method for the patient each pregnancy. Any patient who is antenatal is presenting with the symptoms of fever, night sweat, cough, and weakness. We have to rule out tuberculosis in this patient. So any pregnant woman with unsustained documented fever and for more than 2 weeks, then definitely diagnosis of the tuberculosis has to be done. In pregnancy, all these four drugs, isoniazid, ampicillin, pycnilamide, and ambutal are thought to be effective and can be given in pregnant patients in any trimester. In all first, second, and third trimesters, this drug is thought to be the safe and can be given. Supplementation of phytoxin and vitamin K has to be given to this patient receiving isoniazid and ampicillin as this drug might be associated with and anemia. What are the other advice which you will give to the patients? For having proper diet, plenty vegetables, nutritious food, and antioxidant vegetables, having grains, unsaturated fat, micronutrient supplements. So apart from the routine medications, apart from the routine drugs, having a proper diet is also necessary for the patient. In patients with multi-drug resistant tuberculosis in pregnancy, the drug that can be given are without swimming, dog, meropenem, also levofloxacin, moxifloxacin, imidazolid, and cycloserine. If advantages outweigh the risk, then this drug can be considered. If necessary, this drug can be given after second trimester so that the risk of anemic can be but the drugs that are contraindicated in pregnancy are omeprazole, streptomycin, niacinamide, pyriproxycin, so these drugs should be avoided in pregnancy. Even the fetus, it is present either with congenital TB or it is present with post-natal diagnosis of tuberculosis. The patient, why fetuses have congenital tuberculosis? Congenital tuberculosis it might be because of the exposure to the fetus, either in the placenta or to the umbilical vein. Okay, in the mother, we have acute tuberculosis, it is not under treatment. So, I think it's from the mother to the fetus.
चाय बिस्किट लेके नहीं इतना टोस्ट मत करो। बाकी आप जिम में सर ये वाला चलते सर
Welcome back. I would again like to invite sir to talk about extrapulmonary and management of extrapulmonary.
There is another paradigm on either to use steroid in tuberculosis or not. We observe that there is some impedance that